Hello, my name is Amit Pawa, and thank you for joining me for this talk on the evolution of fascial plane blocks. Now, this was a talk I was asked to deliver as part of a webinar between RUK and the Royal College of Anaesthetists in November 2023 to celebrate 100 years of the BJA. There's been a lot of talk on social media about fascial plane blocks, the pros and cons, so I thought this would be a good time to record this lecture. I have the usual disclosures, which you'll all be familiar with. But when I think of fascial plane blocks, I tend to think of the TAP block and the PEX blocks, because those are the first few fascial plane blocks that I really got used to doing. But how old are these blocks? Well, the TAP block was first described in 2001 by Raffi, and he called it the abdominal field block. Back in 2007, McDonald et al. Did a whole cadaveric and radiological evaluation of the transversus abdominis plane block, as they called it then. And in the same year, Hebard described the ultrasound approach to this block. Well, what about the PEX block? That was first described back in 2011 by Rafa Blanco as an initial injection between PEC major and PEC minor. He then revised this in 2012 and described the modified PEX block, modified PEX 1, which he called the PEX 2 block. And in 2013, the evolution continued when he described this serratus anterior plane block, or serratus plane block as he called it back then. Now, if we take the TAP block as an example, so we started off here with the landmark TAP block. The next iteration was to use ultrasound to perform this transversus abdominis plane block. And when people were using ultrasound, they were placing their probe and doing their injection at a few different locations. They were doing a lateral TAP block at the lateral aspect of the abdominal wall, a posterior TAP block going further back, and they were even performing the block in the subcostal region to get the upper abdominal nerves and performing a subcostal TAP block. But perhaps the whole time what we were really trying to perform was a quadratus lumborum block, and maybe that's what the landmark TAP block was achieving the whole time. But as you know, people have made it even more complicated by talking about the QL1, QL2 and QL3 blocks, either the lateral, the posterior and the anterior QL block. So this is all getting a bit confusing, and there was a rapid expansion of fascial plane blocks shortly after that. So we now know that fascial plane blocks can be performed in the head and neck, they can be performed in the upper limb, they can be performed in the thorax, and also the abdomen, as well as the lower limb. So in fact, fascial plane blocks can be performed around the whole body. And you now know that there has been a rapid expansion of publications just simply looking at fascial plane blocks. The problem is, however, when you look at all of these 3 and 4 letter acronyms, it all gets a bit confusing. And I don't know about you, but when I see all of these names, this is really what I see. It's very confusing, and there are literally too many blocks with inconsistent nomenclature. The good news is that Azra and Ezra got together and produced this Delphi consensus looking at a whole host of abdominal wall, paraspinal and chest wall blocks, and that QR code will take you there. And subsequent to this original webinar coming out, the upper and lower limb nomenclature paper has also come out, and here is a QR code to take you to that paper. So when I think of abdominal wall blocks now, I'm thinking about the TAP block, the rectus sheath block, the quadratus lumborum block, and the external oblique intercostal, which is a relatively new block. If we look at chest wall blocks, we've got what was formerly called the PEX 1 and 2, which now referred to as the interpectoral and pectus serratus. Got the serratus anterior plane block, a parasternal intercostal plane, which has taken over the other names that have been described to describe blocks at the front of the chest, and the ESP. Now, whether you consider the ESP to be a fascial plane block or not is another area of controversy, but certainly it's something that I've put in this category here. And now if we think about lower limb blocks, what are these? Well, we've got the Peng block. It's certainly aiming for a plane. The suprainguinal fascia iliaca, the IPAT block and the adductor canal, they can all be considered to be fascial plane blocks. At this point, I want to highlight 3 important references. The first is a paper I wrote with Hesham El-Shakawi and Ed Mariano called Interfascial Plane Blocks, Back to Basics. And then 2 more interesting narrative reviews. One of them here is Fascial Plane More Questions Than Answers, written by Nick Black, Carla Stecco, and Vincent Chan, and another paper by Keegan Chin and Karim El-Bogdadli, looking at how the ESP might work, another narrative review. So these three important papers. But let's start off by looking at the anatomy of fascia. So what is fascia? Well, it's a soft, collagen-containing, loose and dense fibrous connective tissue that permeates throughout the whole body. And the thing we're most interested in is the deep fascia, which tends to be multi-layer. If you look at that deep fascia, they've got multiple layers, as I said, it's fibrous and extends throughout the whole body, and that is the target for fascial plane blocks. And this deep fascia tends to form sheaths for nerves, vessels, and organs. There are a couple of subtypes. The first subtype is epimysial, which is thin. It tends to be specific to one muscle and adherent to that muscle. And examples of that are the pecs, the taps, and the serratus anterior plane. What about the aponeurotic or the thick fascia? Now, this may cover several muscles. It's easily separated. An example of this is the rectus sheath fascia or the adductor canal fascia. And how do these look? Well, these look like this, and you can see that difference between the two different fascias there, and hopefully that's nicely demonstrated in these images here. The next concept I want to talk about is lines of fusion. Now, these are distinct fusion points, such as the linea alba in the middle of the rectus abdominis muscle, or the linea semilunaris at the side of the rectus muscles, and they create a compartment to hold that local anaesthetic. They limit the spread, which is good for rectus, but it can also be bad because you can have pathological lines of fusions due to surgery or adhesions. The other concept to talk about is fascial interconnectivity. So there can be connections between fascia from one area to another, and many planes are continuous and they can communicate without clear boundaries. This may help us understand the mechanism of action where you inject local anaesthetic in one area and find that the local anaesthetic spreads to another area. An example of here might be a continuation between the gluteal fascia, the thoracolumbar fascia, and the endothoracic fascia. This is a fascinating concept. However, fascial plane blocks are not liked by everybody, and this image here is meant to be taking on Marmite, which is a yeast extract that people use as a savoury snack. Some people really love it and some people really don't. Now, this paper here by Peran Longqvist and Manoj Kamarkar is a slightly controversial take on fascial plane blocks, and it talks about how people rely on a random but favourable spread of the local anaesthetic to get a good block, and they liken this to using a shotgun with the hope that at least one of the pellets hits the clay trap. And they conclude that just because fascial planes exist, it doesn't mean that injecting local anaesthetic into these fascial planes always produces a relevant blockade of local nerve structures. And there are another couple of papers here, again, talking about the potential issues with fascial plane blocks and why maybe using a fascial plane block for a certain procedure isn't always the right thing to do. So if you're interested, have a scan of those QR codes and that will take you to the relevant papers. So what is the mechanism of action of these blocks? Well, we know for a plexus or a peripheral regional technique, it's quite easy. You take a needle, you inject local anaesthetic in the close proximity to a nerve, and that's how it works. But with fascial plane blocks, it's maybe not that simple. What are the proposed mechanisms? Well, one mechanism is you inject local anaesthetic in a plane and it targets nerves in that plane by bulk flow, but also diffuses via a concentration gradient to get nerves in another plane. And that could be like a backdoor or by proxy technique, a little bit like the ESP block. The other option is that you could inject local anaesthetic into one plane, but that local anaesthetic acts at nerves at a distant plane, and that might work by systemic absorption. And there's been some people talking about the fact that the ESP block may work by this technique. So what nerves might the local anaesthetic act on? Well, clearly they could act on cutaneous nerves, such as the lateral cutaneous intercostal branches in the serratus plane. They might work on non-cutaneous nerves, and these are usually ones that have got silent nociceptors, and they could lie in muscles, ligaments, joint capsules, bones, or in other fascia. And these tend to be upregulated in inflammation and injury. Another option is that your local anaesthetic may act on motor nerves. Now, classically, we've always thought of motor nerves as just having that one function to supply muscle, but they also carry sensory or nociceptive input from those muscles. So blocking those motor nerves may also relieve spasm. So you imagine a rib fracture and you've got your serratus anterior muscle in spasm. If you block the long thoracic nerve by doing a serratus anterior plane block, you can see how that may contribute to pain relief. Now, there are also biomechanical properties of fascia, and we know that fascia is dynamic. There's a concept that the pumping mechanism may be due to muscle tendons, can help to distribute local anesthetic. There may even be contractile elements within the fascia, and that might explain why you get variable or extensive dermatomal spread. We also wonder what impact the depth of anaesthesia and muscle relaxation may have on the spread of local anesthetic within fascia. Now, here's an interesting paper. They did a suprainguinal fascia iliaca block on volunteers, and they noticed that passive muscle movement altered the distribution of local anesthetic. So that kind of fits in with that option. And here's another paper where we saw that an ultrasound-guided posterior tap block actually led to local anesthetic spreading via the fascia into the paravertebral space. And there's a whole host of potential explanations for why that might happen. Here's another paper now where they did an anterior quadratus lumborum block, and they showed that local anesthetic spread in this area spread all the way up to the paravertebral space and to the sympathetic trunk. And interestingly, the lumbar plexus was not stained, and that's something that people often talk about with an anterior QL block. They're worried about local anesthetic blocking the lumbar plexus. So if you get it in the right plane, maybe that doesn't happen. So clearly, there are many controversies with fascial plane blocks, and many of them, fortunately or unfortunately, relate to the ESP block. So what do people say? Well, they say, well, look, these fascial plane blocks can be unpredictable. You can get an inconsistent effect, inconsistent efficacy, and there is inconsistent evidence. You look at papers in volunteers and cadavers, we get very conflicting results, and it's very rare to get a dense neural blockade with these fascial plane blocks. We also know that local anesthetic spread can be affected by the thickness of the fascia. So if you have thick fascia, it's relatively easy to identify an ultrasound, but it limits the diffusion of local anesthetic. So it can kind of contain the local anesthetic in a space, but its spread outside that space is limited. By contrast, thin fascia can be harder to identify, but actually if you inject near a thin fascia, you get better distribution of local anesthetic because it can kind of spill out from that area, but the spread that you get is variable. Let's have a look at an example of local anesthetic spread near thick fascia. So this is a rectus sheath block. You can see this lenticular opening of local anesthetic within that space. It's really nicely contained within that area. So this is perhaps the ideal block because you know that that local anesthetic is going to be stuck in that space and it's not going to move anywhere apart from that, which is what we want it to do with a rectus sheath block. But how about these blocks? Now, these blocks have been performed around the pec major and the pec minor. You're looking at variable spread of local anesthetic. Sometimes it's opening up the space, sometimes it's intramuscular, sometimes it's within the fascia. Are these ideal blocks, or is the local anesthetic staying where it needs to be, or is it diffusing to the correct place? It's difficult to tell, really. I don't know. Is this good enough? What we do know, however, is even when you get local anesthetic in the correct plane, the local anesthetic doesn't necessarily stay there. So if we have a look at here's an example of local anesthetic injected around the tap blocks, and the fascial plane is not a closed space. Injectate can spread into the internal oblique and the transversus abdominis muscles via the perimysium. So that could affect the amount of local anesthetic is available to act in the plane that you want it to act in. We also know that there are various receptors within the fascia. There are somatic nerves, which have got sensory and motor innervation, and they take a variable path. There are sympathetic nerve fibers, and then there are nerves to the fascia, this whole concept of a fasciatome. So could action on the last two, the sympathetic nerves and the nerves to the fascia, could they explain why you might get a really successful block, but without necessarily seeing clear dermatomal evidence of blockade? It's possible, right? So is the lack of dermatomal block important? Well, I would argue if there's analgesia and opioid reduction evident, then maybe the fact that you can't test a dermatomal effect of the block is not that important. And clearly, if the patient derives a benefit, does it matter? It may be because you're getting a differential block, and preferentially you're blocking C fibers more than you're blocking A delta fibers. And I think, if you've got patient reported outcome measures and you're demonstrating a minimum clinically important difference in the quality of recovery, then actually the fact that we can't see a dermatomal block demonstrated maybe isn't that relevant. I guess what most people need to know or want to know is how can we improve the efficacy of fascial plane blocks? Well, what we might decide to do is to deposit a local anaesthetic closer to the target. So instead of performing a tap block where the local anaesthetic is deposited at a distance to the nerves, we should be performing a rectus sheath block where we know the local anaesthetic is deposited and contained in closer proximity to the nerves. Maybe we need to inject at more than one site, so don't just inject at one point within the plane, advance the needle and move the needle to deposit it across a large area of that plane. We might want to consider increasing the concentration of local anaesthetic that we're administering, because if you're administering a dilute solution of local anaesthetic, maybe by the time it gets to the nerves, the amount of local anaesthetic able to act is less. So therefore, if we increase the mass of local anaesthetic deposited, that could have a difference. Or we could use epinephrine containing solutions because we're aiming to minimize the amount of local anaesthetic absorbed systemically. And if you're using catheters, rather than just doing a continuous infusion, we know that catheters work better if you use a bolus. It expands the space, you deposit a large mass of local anaesthetic around those nerve fibers, and that's probably more effective than just a continuous infusion. Well, I know what you're going to say, just stop a minute. We've got all of these old blocks. What's wrong with them? And that's a really great question. So what's wrong with old techniques? Well, from an efficacy point of view, actually probably nothing. And I think you would argue that a thoracic epidural is unrivaled when you're talking about abdominal analgesia. But from an enhanced recovery after surgery point of view, actually there are possibly a few things that are wrong. Number one, in many centres now, if you're siting an epidural, you need to have a patient in a specific high dependency area. So you need to have a patient in the correct level of care. Certain techniques, certain blocks will limit the patient's mobility, and that can be a problem when you're talking about enhanced recovery. And lastly, sometimes when you're using a block that creates a significant sympathetic blockade, you might need to co-administer a vasopressor. That is an issue. The other thing to consider is if we're now performing less blocks because they're not designed because of enhanced recovery, then fewer of these blocks are inserted, fewer are taught, then people have lack of confidence when it comes to inserting an epidural, for example, then fewer patients receive them, and we're not that good at inserting them. And this is basically a vicious circle. So if we're not using them that much, then people are going to perform them less and teach them less, and less people are going to be confident performing these blocks. So I think we now know that fascial plane blocks are being used more. Now, they can impact outcome measures. We know that. And what type of outcome measures are we talking about? We're talking about pain scores, opioid reduction, and nausea and vomiting. So they do have a role. We also know that they can have positive impacts on drinking, eating, and mobilization. Also, they can affect mood, independence, sleeping, and breathing. So fascial plane blocks can impact these. But there are other things that fascial plane blocks can impact, and there are other ways that they can have a positive role. So what are these? So they can allow delivery of analgesia pre-hospital. They can allow delivery of analgesia by all grades of anaesthetists, also by multiple specialties, and maybe even by non-physicians. And the other thing that's really relevant is you can cite many of these fascial plane blocks even in patients who have altered coagulation status and in patients who are large and small. I don't just mean adult or pediatric, I mean of patients in varying body mass index. So certainly, if fascial plane blocks allow you to do all of these things, they're increasing patients' access to regional anaesthesia. So if you think about some high-risk patients, what about rib or hip fracture patients? They often have significant morbidity associated with these pathologies, but many of them are on anticoagulants. And certainly, if you're thinking about these patients, they benefit from opioid-reducing analgesia, but many of them have contraindications to deeper blocks, such as a thoracic epidural. So we need a simple technique that all can perform. And that's where, for hip surgery, you can perform a suprainguinal fascia iliaca block or a pain block. And for rib fractures, you can perform ESP or serratus plane. So that has a potential role. What about chest or abdominal wall cases? If you think about patients having mastectomy, there is often this fear of performing a paravertebral block, or laparotomy and liver surgery and bariatric surgery. These patients often don't receive blocks. Well, thinking about fascial planes, you know that we want to do something for these patients to reduce their opioid usage. Many of these patients may still have contraindications to deeper blocks, so we need a simple technique that all can perform. What are the options here? Well, you can perform interpectoral pectus serratus blocks, ESP or serratus plane, or tap rectus sheath, quadratus lumborum block, and the external oblique intercostal. So there are options, and there is a role for fascial plane blocks in these particular types of surgeries. Are there any papers that talk about the use of or the benefit of fascial plane block? Well, there's a slightly controversial editorial that we wrote in the BJA, and we talk about the fact that the ESP isn't the ultimate plan A block, but it can be performed at all spinal levels, and there are several meta-analyses that show a reduced opioid use and pain for 24 hours. We also talk about the fact there's a benefit in the rib fracture population, and the fact that the European Society of Anaesthesia and Intensive Care, the ASRA, and the Canadian Association of Regional Anaesthesia guidance on anticoagulation blocks support the use of this technique. And we also emphasize the safety and simplicity of this particular technique. Here's another paper here where they look at the efficacy and safety of non-neuraxial techniques for midline laparotomy, and this was a systematic review and network meta-analysis. What did they do? So they looked at 67 studies with just over 4,000 patients, and they specifically looked at 24-hour opioid consumption and resting pain scores. And what they noticed was continuous rectus sheath and continuous tap blocks were most efficacious. And they concluded by saying we should consider single shot tap blocks, single shot rectus sheath blocks, and single shot quadratus lumborum blocks. So that QR code will take you to that paper. Now, it's probably time we talk about PEX blocks, because there's been a whole host of work looking at PEX blocks. And what can we say about them? Well, when we look at the PEX2 blocks, it certainly reduced pain scores, it reduced opioid requirements, and it may be as effective as a paravertebral block. I find that last one hard to believe, but certainly it's what some of the evidence suggests. I also did a narrative review with Keegan Chin and Barbara Versick, and we highlighted the fact that PEX, serratus, and ESP have a significant benefit in breast and thoracic surgery, and also fascial plane blocks have a role in trauma and cardiac surgery, and it has great potential. And we also again commented on the fact that PEX blocks had a similar outcome to paravertebral blocks. So where may fascial plane blocks have a role? Well, certainly, if you can't cite an epidural, a spinal technique, or a paravertebral block, and there may be examples of this such as those with autocoagulation, in sepsis, and certainly in certain specialties like cardiac and transplant surgery. And if you're concerned about the potential effect of hypotension as a side effect of a central neuraxial technique caused by sympathectomy, that's where fascial plane blocks may have a role. It may be that you've cited one of those original techniques, but actually they've failed, and you need a rescue technique. That's where fascial plane blocks may have a role. Or if you are unable to cite an epidural or a paravertebral block, now that may be due to patient positioning. They've got rib fractures, you can't turn them on their side, or it may be because you haven't got a skilled practitioner to perform a thoracic epidural, or it may be you haven't got someone to monitor a patient afterwards. That's certainly a role or an indication for fascial plane blocks. So if I was to summarize the evolution of fascial plane blocks, this is what I think has happened. So we started off with these innovators, people that come up with this idea and these techniques and get us all excited. So we're enthusiastic and we try adopting them into our everyday practice. That whole practice has inspired a whole host of new blocks that come out, but sadly, this has led to some confusion and the evidence hasn't kept up with the innovation. But now, as the evidence is improving, we're now starting to rationalize certain blocks and now integrating them into pathways. So we've got guidelines or pathways for managing certain patients. You can see how fascial plane blocks may have a role, and a perfect example of this is rib fractures, for example. So if we look to the future, what do we want research in fascial plane blocks to answer? Well, I think we need to know whether fascial plane blocks have an impact on long-term outcomes. We also need to know what is the ideal local anesthetic volume and the local anesthetic concentration, because one of the big concerns is using a large volume of local anesthetic in a plane, then the risk of local anesthetic systemic toxicity. We also need to know which blocks that we perform have the most impact. Does ESP really have a role for rib fractures? Is serratus anterior plane better? what block works best for hip fractures. We need to know which of those techniques makes a big difference. And also we need to know, is there any value of adding adjuncts to our local anaesthetic solution to maximise the duration of action of these blocks? So how can I conclude this brief talk? Well, I think what we can say is that fascial plane blocks are a heterogeneous group of techniques. We don't really understand how they work, certainly not in the same way that you understand how a peripheral regional anaesthetic technique works, like a interscalene or a femoral nerve block. They're not always predictable in their action, but what we can say is that they may have a role in the absence of a traditional technique, such as an epidural or a paravertebral. If you can't cite them for some reason, that's where fascial plane blocks may have a role, because ultimately what they allow us to do is to increase the delivery of regional anaesthesia to patients who may otherwise not benefit from them. So hopefully that's given you something to think about. Thank you very much for listening, and I hope to see you all soon.